Good morning, everyone. The topic of today's presentation is multiple myeloma. It is the most common primary malignancy of bone. Malignant transformation of a single plasma cell clone is usually seen. Plasma cells proliferate and infiltrate the bone marrow, displacing the normal marrow and initiating secondary changes in the surrounding bone. It may be a solitary plasmacytoma or solitary myeloma, or it may present systemically as multiple myeloma myelomatosis. Incidence is of 3 to 4 per 1 lakh population, and the incidence is more in males compared to females, a ratio of 2:1, and it is common in the 5th to 7th decades of life. Malignant plasma cells are monoclonal, variable region of immunoglobulin molecule that each malignant cell produces chemically and structurally identical. Production of immunoglobulins by malignant cells, that is IgG, is more produced, followed by IgA, IgD, IgE. Multiple myeloma is distinguished from solitary myeloma and requires the presence of plasmacytoma or greater than 10% plasma cells in bone marrow examination. Monoclonal paraprotein in the serum or urine. Organ dysfunction related to myeloma. Most common sites of multiple myeloma include spine, which is followed by ribs and pelvis. The tumor, its production of host results in number of dysfunctions and symptoms. Bone pain or fracture. It is almost in 70% of the cases, multiple myeloma presents as bone pain associated with a pathological fracture. Then it is associated with renal failure, susceptibility to infection, anemia, hypercalcemia, occasional clotting abnormalities, neurological symptoms, and manifestations of hyperviscosity. Etiology: the exact cause is not known. Infection, genetic predisposition, and various environmental factors, including radiation and chemical exposure, have been implicated. Tumor may grow in perioral soft tissues and parenchymal organs, but usually presents either as a solitary osseous lesion, plasmacytoma, or multiple punched out bone lesions, or diffuse marrow infiltration. Then myelomas often have chromosomal translocations involving the IGH locus on chromosome 14 and various other genes, including cyclin D1, fibroblast growth factor receptor 3, and cyclin D3 genes. Late in the course, translocations involving MYC are sometimes also observed. As might be summarized from this list of genes, dysregulation of these cyclins is common in multiple myeloma. The chromosomal alterations seen in multiple myeloma include hyperdiploidy, 13q14 deletions, translocations in T1114, T414, T1416. NRAS, KRAS, and BRAF mutations are common, which occurs in more than 40% of the patients. It's the normal proliferation. Pathogenesis and clinical manifestations. Multiple myeloma cells bind to bone marrow stromal cells and extracellular matrix via cell surface adhesion molecules (CAM). They causes adhesion mediated signaling, and this causes induction of various cytokines, which leads to cytokine mediated signaling, which triggers cell growth, survival, drug resistance, and migration in bone marrow. Here, as depicted in the diagram, we can see a multiple myeloma cell attaching to a bone marrow stromal cell via adhesion molecules, also known as CAMs, and this causes cytokine mediated signaling and release of cytokines, which causes which gives the cells specific characteristic properties such as proliferation, drug resistance, cell cycle, anti-apoptotic feature, etc. Pathogens and clinical manifestation. Most common symptom, it is bone pain in 70% of the patients. Persistent localized pain usually signifies a pathological fracture. Bone lesions are lytic in nature and are caused by proliferation of tumor cells, activation of osteoclasts, suppression of osteoblasts. Increased osteoclastic activity is mediated by the osteoclast activating factor OF, and it is produced by myeloma cells, which is mediated by the interleukin 1 lymphotoxin VEGF, receptor activator of NF kappa beta ligand, macrophage inhibitory factor 1 alpha, tumor necrosis factor TNF. This bony lysis leads to hypercalcemia. Radiologically, multiple myelomas appear as multiple punched out, sharply demarcated, purely lytic lesions without any surrounding reactive sclerosis. Here we can see the typical punched out lesion of skull. The lack of reactive bone formation is also shown by the fact that most lesions are negative on bone scan. Occasionally, myeloma is characterized by marked bone expansion, giving rise to a ballooned appearance. Pathogenesis and clinical manifestation. Usually there will be a vertebral collapse which leads to cord compression, which leads to radicular pain, loss of bowel bladder control, etc. And the second most common clinical problem is the susceptibility to bacterial infection. And most common infection is pneumonias and pyelonephritis. More than 75% of patients will have a serious infection at some time in their course. The reason for susceptibility to infection is due to diffuse hypogammaglobulinemia. That is, there will be both decreased production and increased destruction of the antibodies. Also, there will be decreased Th1 response. Complement function abnormality will also be there. Renal failure is present in more than 25% of patients. Most common cause of renal failure is hypercalcemia. Other causes include glomerular amyloid deposition, hyperuricemia, recurrent infection. Tubular damage associated with excretion of light chain is almost always present, and that we call as Bernstein's proteins. Normocytic normochromic anemia is seen in 80% of the patients. Granulocytopenia and thrombocytopenia are rarely seen. Clotting abnormalities due to failure of the antibody-coated platelets to function properly. DVT is observed with use of thalidomide. Hyperviscosity syndrome may lead to headache, shortness of breath, heart failure, visual disturbances, ataxia, vertigo, retinopathy. Hypercalcemia can lead to lethargy, weakness, depression, and confusion. Coming to the diagnosis and staging, diagnosis usually can be confirmed by serum immunoelectrophoresis, which shows a monoclonal gammopathy. Diagnosis of myeloma requires maroplasmacytosis more than 10%, a serum and or urine M component. Evidence of one or more end organ damage that can be attributed to the underlying plasma cell proliferative disorder, specifically hypercalcemia, that is serum calcium level of more than 0.25 millimoles per liter, that is more than 1 milligram per deciliter, higher than the upper limit of more than 11 milligram per deciliter. Renal insufficiency, that is creatinine clearance of less than 40 ml per minute, or serum creatinine more than 177 micromoles, that is more than 2 mg per deciliter. Anemia, HB value of more than 20 gram per liter below the lower limit of normal, that is below HB value of below 100 gram per liter. Bone lesions, one or more osteolytic lesions on skeletal radiography, CT or PET CT, any one or more of the following biomarkers of malignancy, such as clonal bone marrow plasma cell percentage more than 60%, involved uninvolved serum free light chain ratio of more than 100, more than one focal lesions on MRI studies. Standard investigative workup in multiple myeloma include the evaluation of the clonal plasma cells. Bone marrow aspirate biopsy is the most commonly done and most important investigation to be done, where histology is done. Clonality by kappa lambda immunostaining by flow cytometry or immunohistochemistry. Histologically, multiple myelomas appear as sheets of plasma cells. These are small round blue cells with a clock-faced nuclei and abundant cytoplasm with a perinuclear clearing or halo. Amyloid production is seen in abundance. Investigation to evaluate clonal paraprotein, serum protein electrophoresis and immunofixation, quantitative serum immunoglobulin levels IgG, IgA, IgM, 24-hour urine protein electrophoresis and immunofixation, serum free light chain and ratio, immunofixation or IgD or IgE in selected cases. Investigations to evaluate end organ damage. Hemogram for anemia, leukopenia, thrombocytopenia. ESR is usually raised often above 100. A chemistry panel for renal function and calcium. Skeletal survey to evaluate bone lesions, PET CT or MRI. Investigations for risk stratification. Beta 2 microglobulin and serum albumin for ISS stage. Fluorescent in situ hybridization for hyperdiploidy and LDH. Specialized investigations in cases include abdominal fat pad for amyloid and serum viscosity. The beta 2 clinical examination, careful physical examination for tender bone and masses, chest and bone x-rays, lytic lesion or diffuse osteopenia may also be seen. Differentials. The most important differential diagnosis in patients with myeloma. In patients with solitary plasmacytoma, the pathology differential diagnosis include chronic osteomyelitis with abundant plasma cells. Plasmacytoma exhibits monoclonal kappa or lambda light chains, whereas the plasma cells of chronic osteomyelitis are polyclonal. Also, myeloma cells usually stain positive for the natural killer antigen CD56, whereas reactive plasma cells usually do not. In poorly differentiated cases, lymphoma could be in the differential diagnosis. Immunohistochemistry is helpful in differentiating it from lymphoma. Then MGS, monoclonal gammopathy of undetermined significance. Smoldering multiple myeloma, it's also asymptomatic myeloma. The features which help in differentiating it from multiple myeloma are given criteria. Prognosis. Serum beta 2 microglobulin is single most powerful predictor of survival. There's a 3-stage international staging system where the beta 2 microglobulin level, if it is less than 3.5 and albumin more than 3.5, it is stage 1 where the patient is having a 62 months median survival months. Beta 2 microglobulin level of less than 3.5, albumin less than 3.5 or beta 2 microglobulin level between 3.5 to 5.5, it is stage 2 with a median survival of about 44 months. Beta 2 microglobulin level more than 5.5, it is stage 3 where the median survival in months is reduced to 29 months. Or between 3.5 to 5.5. Less than 3.5. Sir, we consider beta 2 microglobulin as most important. So, that 3.5 and stage 3. More than 5.5. More than 5.5. അവിടെ നമ്മൾ സെക്കൻഡ് ഓപ്ഷൻ 3.5 to 5.5 ബീറ്റ 2 മൈക്രോഗ്ലോബുലിൻ ലെവൽ വന്നു കഴിഞ്ഞാൽ സ്റ്റേജ് 2 തന്നെ ആവില്ല. സ്റ്റേജ് 2
ഇപ്പൊ 3.5 താഴെയാണ്, പക്ഷെ ആദ്യം 3.5 താഴെയാണ് സ്റ്റേജ്.
Treatment. Patients with symptomatic and progressive myeloma require therapeutic intervention. It has two purposes: systemic therapy to control myeloma, and supportive care to control symptoms of the disease, its complications and adverse effects of therapy. Individual bone lesions are highly radiosensitive. Local radiation therapy can be given to solitary bone lesions. Anti-RANG ligand antibodies and bisphosphonates arrest the progress of osteolysis but do not necessarily alter the overall progress of the disease. Bisphosphonates is already yes, yes. Treatment regimens. Therapy includes an initial induction regimen followed by consolidation and maintenance therapy. Newly diagnosed multiple myeloma patients, thalidomide plus dexamethasone response in two-thirds of cases, lenalidomide plus dexamethasone response in more than 80% of cases, bortezomib plus dexamethasone response in more than 80% of cases, lenalidomide plus bortezomib plus dexamethasone 100% response rate, bortezomib plus thalidomide plus dexamethasone more than 90% response, bortezomib plus cyclophosphamide plus dexamethasone more than 90% response. Patients who are transplant candidates, alkylating agents should be avoided. High dose therapy and maintenance are standard practice in majority of eligible patients. Two successive high dose therapies are more effective than single high dose therapy. Maintenance therapy prolongs remissions following standard dose regimens as well as HDT. In case of relapsed disease, almost all patients with multiple myeloma who survive initial treatment will eventually relapse. Relapsed or refractory multiple myeloma is usually identified on routine surveillance, and therapy options are high dose therapy, re-challenge of previous chemotherapy regimen, a trial of new regimen. Standard therapeutic agents. This is the flow diagram for how to approach a case of myeloma. Transplant, we should be avoiding alkaline. Renal transplant. Kidney disease. Treatment.
അവരങ്ങനെ തിരിഞ്ഞു പോണതാ. അവരുടെ ഹെമാൻഡി ഹെപ്റ്റാൻ്റെ കോഴ്സ് അല്ല, മെഡിസിൻ കഴിഞ്ഞു ഇന്നവേറ്റ് മാത്രമല്ല റിസർച്ച് എങ്ങനെ ചെയ്ത് അതാ ഇൻസ്റ്റിറ്റ്യൂഷൻ പ്ലാൻ തന്നെ വർക്ക് ഇൻസ്റ്റിറ്റ്യൂട്ടിലേക്ക് വരുമ്പോൾ നോക്കുള്ളൂ. ഇൻസ്റ്റിറ്റ്യൂഷനുണ്ടോ വീരമോഹൻ അച്ഛക്ക് സിവിലുണ്ട്
Coming to that treatment continuation, the median overall survival of patients with multiple myeloma is 8+ years, with younger patients surviving more than 10 years. Supportive care, hypercalcemia, they respond to bisphosphonates, glucocorticoids, hydration, calcitonin, kyphoplasty and vertebroplasty in painful collapsed vertebra, hyperviscosity syndrome, treatment of choice is plasmapheresis.
ഇതേ ബാക്കിയുള്ളവർ നോക്കിയിട്ട് ചെയ്യാൻ
In patients whom neurology deficit is increasing, surgical decompression of spine may be necessary. Anemia respond to erythropoietin along with hematinic, iron, folate, cobalamin.
ആ